February 18th, Tuesday, and today we're kind of continuing our conversation about reference-based pricing. If you remember, we had the office of our auditor come in, Tim Ash, and he gave us kind of a high level of the report that they had done. And I thought we might want to dig a little deeper into it. So we reached out to a couple people in other states with experience in it to share with us their experiences and knowledge and expertise. And we're delighted to have Margaret Smith Isa in with us. So thank you. Welcome.
Yeah, thank you so much for having me. Can everyone hear me all right?
Yes, very well.
Great, wonderful. Well, Chair, Vice Chair, members of the committee, for the record, my name is Margaret Smith Isa. I am a program specialist with the Oregon Health Authority. And I was invited to meet with you today to share a little bit of background information and information on the impact of a Medicare reference-based pricing policy that we put into place in Oregon back in late 2019, early 2020. The provision was passed by our state legislature in Senate Bill 1067 during the 2017 session. And it placed a limit on the level of payment that would be provided for inpatient and outpatient hospital services for state employee health plans. And so I am going to share a slide deck. Now, I hope when I do this, I can still see hands and questions that might come up, but I'm not quite sure how it'll all look on my screen. So please just interrupt if, or, speak up if there's something that's not clear, and I'm happy to take questions as I go, or at the end of the slide deck. I think the slides probably will take about 20 minutes, and I'll defer to the chair in terms of how this group prefers to handle the questions.
Great, and I'll be watching for questions, and I'll interrupt you if at appropriate places.
I got a question.
Oh, we already have a question.
I want to see if I heard you correctly. Thank you. Was this, you said, for state employees only?
Yes, it's I'll get into the details of exactly who it is in the slides. It is state employees and K through 12 school districts in the state.
Okay.
So yeah, and I've got some more detail about all of that to come. So let me get these slides up and make sure. Can everybody see the slide deck?
You can, thank you.
Okay, and let me see if I can make it bigger so that you're not looking at, ooh, let's see if we can, sorry about that, give me just a minute. This is appearing a little bit odd on my screen, so I just want to try to make it.
That's good.
Okay, does that work? Yeah, I prefer to try to make it as big as possible. I know that makes it easier for everyone to see what they're looking at. So again, as I mentioned, my name is Margaret Smith Isa. I am with the Oregon Public Employees Benefit Board and the Oregon Educators Benefit Board, which are two public employee health plan programs within the Oregon Health Authority. Just a little bit of overview of what these slides cover. I'll share a little background about our benefit plans, some high-level information about sort of the challenges we were confronting and continue to confront around cost growth and payment variation. That'll probably sound pretty familiar. I'll give a little bit of the background and details around Senate Bill 1067, which was passed in 2017 and is the bill that placed limits on our level of payment for hospital services. And then I'll talk about the savings, impact, and considerations we've experienced in implementing this policy. So the Oregon Educators Benefit Board and Public Employees Benefit Board are Oregon's two sort of large public sector employee health benefit programs. OEB, as we call it, provides benefits for employees and their dependents in 240 school districts and community colleges across the state. And then PEB, as we call it, does the same for over 200 state agencies and universities, part of the Oregon University system across the state. Together, the programs cover about 300,000 people. About 100,000 of those are employees, and then the remainder are dependents. That represents about 15% of the state's commercially insured population. Also do want to note that a law was passed several years back that permits local government jurisdictions in the state to elect to join either PEB or OEB for their employee benefits. We are starting to see sort of increasing numbers of those cities and counties and local jurisdictions taking a look at our benefit programs and in some cases choosing to opt in and offer benefits through PEB or OEB. At this point, that local government jurisdiction population represents about 3% of our total and is growing. So just kind of a little bit of sort of high level PEB and OEB. So both programs, OEB and PEB, each have a separate board, a governor appointed labor management board that governs the benefit programs. The boards really strive to provide comprehensive, high quality benefits to the agencies, universities, and school districts that employ our state workers and educators across the state. The boards really seek to ensure the benefits promote prevention, support employee health, and advance health equity. There's also very specific attention to ensuring that the plans remain comprehensive yet also affordable to the employers and employees who have PEB and OEB coverage. So going back a little bit in time, and you'll notice the data on this graph is from sort of the earlier part of the recent past, mid 2010s in particular. And I do want to note we contract with Mercer Health and Benefits for our actuarial and consulting services. So this data was provided by them. But if you look kind of going back over time, I think this probably resonates with your group, but sort of the annual change in total benefit costs has, looking back over the years, exceeded annual changes in worker earnings and overall inflation. There's been some closing of that gap in the very recent past, but leading up to 2017 for a long time, there was, real challenges associated with the extent to which employee benefit costs were increasing annually relative to kind of other cost increases in the ecosystem. Additionally, looking at sort of our payments for providers, and this data is very specifically looking back in 2017 at large hospitals in Oregon, but it's commonly noted that there can be a wide range of variation across the payments given to particular providers, similar providers for similar services. Back at that time when we looked at the range in payments on inpatient hospital services, they ranged from about 185% of Medicare to 340%. On the outpatient side, 215% to 375% of Medicare, with not really connection or discernible relation to quality or outcomes or rationale as to why the ranges were so broad and different across providers. And again, these being large hospitals, generally, similar providers, not that they're, every hospital is unique. So not that there aren't some differences, but really even just looking at those larger facilities, the variation existed. So leading up to that, and extensive discussions, a lot of look at drivers of cost increases, hospital unit cost commonly being identified as a significant area of cost driver at the time. The state legislature back in 2017 passed Senate Bill 1067. And the bill was a pretty large bill. It included a lot of different provisions, but two specific major provisions related to public employee health benefits. The first was that the bill placed a 3.4% limit on OEB and PEB benefit plan annual cost and premium growth. Now, prior to this time, we had always been aiming for a 3.4% annual target in our cost growth. This bill, Senate Bill 1067, put that into statute. So per statute, OEB and PEB benefit plans cannot increase in cost more than 3.4% a year. In addition, the legislation incorporated a limit on the amount that insurers and third-party administrators that contract with OEB and PEB can pay for inpatient and outpatient hospital services. And we will, in the coming slides, really sort of dig into that second bullet point. So in terms of that hospital payment limit, what 1067 did was it prohibited insurers and TPAs that contract with OEB and PEB from paying more than 200% of what Medicare would pay on a claims for inpatient and outpatient services at network hospitals. For non-network hospitals, the limit was lower. It set the limit at 185% of what Medicare would pay. The bill applies to hospital services only, so it does not include professional fees provided in a hospital setting. It also does not apply to hospital services delivered outside of Oregon. And that specific provision was actually passed in a follow-up bill in 2019, House Bill 2266. So that was before the policy went live, but after the 2017 law was passed. The specific statutory language also prohibits hospitals that are paid in accordance with that limit from balance billing. And the statute also specifies criteria for exempt hospitals, those generally being the small rural hospitals. Oregon has 62 hospitals, and 24 of those hospitals fall underneath this payment limit. Generally speaking, it's the large DRG hospitals in the state that are under the cap.
We have a question, Lori.
Yeah.
Thank you. So can you just provide more details on that the 24 of the state, 62 hospitals are under the payment limit? What do you mean by payment limit? And then you just used an acronym there that began with a D, and I don't know what that is. But I just understand, because we're such a rural state, most of our hospitals are in rural communities. So how did you go about exempting this and why?
Yeah, so the statutory language, that's a great question. Yeah, thank you. Happy to share some more context there. So in terms of the hospitals that are exempt, it's type A and type B hospitals, which are defined in state statute. It's also critical access hospitals. And I will tell you high level for type A and type B hospitals, and I don't have the language right in front of me. So, but one is hospitals that are, I believe it's more than 30, fewer than 50 beds and more than 50 miles from the next nearest hospital. And the other is like is fewer than 50 beds, but less than 30 miles. It's basically for type A and type B, there's a size and distance criteria. And so as long as if the hospital falls within that size and distance from the next nearest provider criteria, they're considered a type A or type B hospital, and those are exempt. And so it's basically focusing on hospitals that are smaller, may be the only provider in the relatively nearby area, but may not have a critical access hospital designation. So it exempts the critical access hospitals and then the type A and type B. And then there's some additional criteria around, and I would be happy to follow up with staff and share the specific statutory language, but it has to do some additional exemption criteria that looks at the population of the county and the percent of the hospital's total revenue that's received from Medicare. And that additional criteria, there are a couple of other hospitals that are exempt under that additional criteria. Now, the 24 of the hospitals that are under the limit, I mentioned those are sort of the larger DRG hospitals, and DRG is the diagnosis-related grouping. It's the ones that are paid under inpatient prospective payment system for Medicare. And I am not like a Medicare payment policy expert, but they are the large hospitals that are paid under DRGs from Medicare's payment approach.
So they are also exempt from this law?
No,
No,
those
those are the ones that are
larger,
in it.
yes, the 24 larger ones are the ones that are under this payment cap. And then the remainder are exempt. So it's the whatever I should be able to do this math at the
But
top of my head.
No, that's fine. So that's great. Thank you. So my next question is,
Mhm.
you may not know this, what was the rationale behind exempting the smaller rural hospitals? What did they think would happen if they were included?
That's a great question. I can't speak specifically to all of the considerations that went in during the
That's fine.
negotiation process, but I can tell you just sort of like broadly, there are a lot of considerations around volume, access in the community. I think, Medicare does recognize that rural hospitals under Medicare aren't paid under sort of a prospective payment system. They have more of a cost-based reimbursement approach. I think really a lot of the consideration was in looking at sort of how does Medicare also treat different hospitals differently. For the larger hospitals where Medicare does sort of in the inpatient prospective payment system approach to reimbursement, where hospitals get a DRG rate, and the notion is that rate reflects what the hospital should be able to in terms of what the amount that the hospital should be able to provide care for that amount. I think, when you look at rural hospitals, just like even Medicare in the payment approach recognizes their cost structures are different,
Yeah.
and approaches reimbursement differently.
Okay, thank you. I appreciate that.
And if I could just follow up on that.
Yeah.
Was there a cost analysis that was done prior to this? And was it that they felt that the larger hospitals were what were driving the increase in costs more than sort of these critical access hospitals or smaller?
I can't specifically state that like there was a definitive finding that, but I do think that like when you look at volume overall, so these 24 DRG hospitals that are under this payment limit represent overwhelmingly like the bulk of the utilization in the state. Like for our state employee benefit programs, it's 65 to 70% of our hospital utilization. There was quite a bit of analysis done at the time. I can't speak to like the specific findings of every single analysis done, but I think there was, broadly speaking, within the health policy arena, I think, there is a recognition that like larger hospitals that provide kind of more comprehensive services and may provide some of the more intensive, more skilled services, more, technologically advanced services, and do larger volume, that like they do have a different cost structure than say like a small hospital in a rural community that really maybe first of all doesn't offer as many services, and also maybe really doesn't provide any sort of more advanced level of care, where they're typically transferring patients out if they need something more advanced. I certainly think that all of that was heavily deliberated, and in terms of like exactly who you exempt and where you kind of make that determination, I think is a feature of this that's very local. I do think that in different states, exactly what your collection of hospitals looks like and what the considerations are is certainly could vary from state to state.
Thank you.
Yeah, I hope that's helpful.
Mhm. Oh, I'm sorry. One more question.
Yeah.
No. I wonder what, maybe you don't know this, But those hospitals that are not under the payment limit,
Mhm.
how far above the Medicare payment level are they? Under
Yeah.
normal circumstances?
Yeah, that is a great question. We do track that. I mean, we do look at it, and we sort of annually look at level of payment and where everyone is falling in relation to Medicare. They are higher. They are higher than the 200% level. I cannot off the top of my head recall sort of exactly where they are as a group, but we do look at that, and they are. I mean, those smaller, more rural facilities are for our populations. When we look at our payment levels, they are hitting above the 200% of Medicare cap that applies. I should say that applies to the large hospitals. The 200% of Medicare cap doesn't apply to them. So,
Thank you.
yeah, you're welcome. So moving ahead, as we got into implementation and working on sort of putting this policy into place, and as I mentioned, this was passed in 2017 by the legislature with an effective date of it took effect October of 2019 for our educator population. They have an October 1st plan year start. And then for the state employee population, it took effect January 1st, 2020, because we're on a calendar year plan year for that population. And so there was a runway of about 2 years to sort of onboard for our carriers and TPAs to flesh out the contracting with hospitals and get this policy put into place. And during that time, we also worked to develop some further guidance in agency rules. So we issued administrative rules to address some of the specifics around implementation. And there were a couple of particular provisions that we noted in rule. We exempted CMS designated children's hospitals. Specifically in rule, we noted that CMS designated children's hospitals that are not paid under inpatient prospective payment system. We only have 3 of those in the state. They're also excluded from this policy. And really in that regard, during our implementation process, we worked with our health plans and had a public rulemaking process where we issued draft rules, had a public comment period, accepted and reviewed and considered comments, and ultimately landed on final rules. And for the children's hospitals, because again, those are not reimbursed under an inpatient prospective payment system, and also, frankly, Medicare is not a big payer for children's hospitals. There are just a variety of reasons why we determined that when it came to setting a percentage of Medicare payment limit for hospital providers, it made sense to exempt those children's hospitals. Additionally, our rules also included some specific clarifying language. And I should note, we added this clarifying language to our rules in 2020 after we had already implemented the cap. And it was specifically in response to the need to sort of clarify exactly how carriers should be processing payments under this cap. And what we specified was that the actual payments are the lesser of the billed charges, the insurer or TPA's contracted rates, or the statutory payment limit, that 200% of Medicare ceiling. And specifically to note, Medicare is not necessarily the best benchmark for certain types of care that is uncommon in Medicare's enrollee population. For example, we notice this specifically with maternity care and newborns. For these sorts of services, payments that were at or near the 200% of Medicare level really results in a payment level that is far above the typical commercial rate. And so what we noticed early on was that in cases where hospitals were aiming to try to get as high as possible or as close as possible to that 200% of Medicare ceiling, where that was happening on maternity and newborn claims, they were coming in far higher than what a commercial claim would typically come in at. Hence, we work through our rulemaking process to really specify that payment ceiling is not intended to be the price or the payment for everything at 200%, but rather that the actual payment would remain at either, whatever the lesser of bill charges, the insurer TPA's contracted rate, or the ceiling. So that if an insurer or TPA is out there talking with a hospital and they're able to contract for a rate that's less than that 200% of Medicare amount, we pay the lesser. So, and I note that because you'll see as we get into a little bit of the data on savings that in the initial year, our savings were not as high as we had projected on the inpatient side, specifically due to this issue. Some other information about the payment limits. So the carriers and TPAs that we contract with, they negotiate the contracts with providers. So OAB and PEB, we do not actively participate in those negotiations. I can tell you, however, that no contracted hospitals left the network due to the payment cap. So every hospital that was under contract with a carrier prior to the cap remained under contract. Certainly, I think this third bullet point is to be expected. Hospitals did express concerns about potential impact on their revenue. There was certainly a lot of discussion about that when the bill was being debated in the legislature. There was additional, discussion continued about that as we were going through our public rulemaking process. So that certainly was a consideration, and it was part of the discussion. Additionally, and I noted this a little bit on the previous slide, we did observe some indicators that hospitals were seeking increases up to the 200% of Medicare limit on services that were previously paid below that level. So, within a hospital, service by service, there would be a variety of, arrangements in terms of where the payment level would land. And we did see some indications that hospitals were trying to get every service up to that 200% of Medicare level. We have seen that the clarifying language we put in rule specifying the lesser of billed, contracted, or the payment ceiling has really helped address that issue.
I think we have a question on this, Alan.
Okay, I got, when you talk about contracted hospitals, when they sign a contract, is this a 1 year, 5 years, or what's the time limit on contract hospitals?
Yeah, it varies. I mean, the specifics of the contract vary a little bit by carrier. We contract with, so for OAB, we contract with two carriers. OAB is fully insured, and then PEB, we have one fully insured HMO plan, and then we've got two different self-insured TPAs for a couple different plan types. So the specifics of the contracts vary a bit by carrier. Carriers will note that some of their contracts are multi-year. Some of them are renegotiated annually. So I can't tell you, I don't think one answer. I think there's a little bit of a range. I do think that, even the multi-year contracts, they don't go on for that long without being renegotiated. I mean, I think generally speaking on the hospital contracts, maybe 1 to a few years on most of the contracts.
Thank you.
You're welcome.
Oh, one more question.
Could you tell us what the impact on the hospitals is?
I can't speak specifically to what the impact on each individual hospital is in terms of, their revenue. That's information I don't have. I mean, I do think we have some other analytical units within the health authority that might have a little bit more information on that than I do.
Maybe we don't need numbers, but how are they progressing now with this legislation in place?
Yeah,
Is it
so
affecting their revenues negatively or positive?
well, I mean,
Or
I
does it make
can't.
a difference?
Yeah, I can't tell you. I mean, I think I can't speak for the hospitals. I can tell you that, hospitals in Oregon, I think, over the past several years, there have been a number of factors that have challenged the healthcare delivery system as a whole. And so, one of the things to note is that this policy took effect, like I said, late 2019, early 2020 in our state. And within a few months, the COVID pandemic hit. And there were pretty radical changes to, and impacts to the delivery system in terms of, deferral and stoppage of elective services for a period of time, in terms of, just challenges with the whole climate around healthcare delivery for a period of time. And so I think certainly hospitals have experienced, operating and revenue challenges similar to what we've heard across the country. I mean, that has happened in Oregon too. And then coming out of the pandemic with challenges with labor costs and things of that nature. So, I think it's fair to say that hospitals in our state have experienced those types of cost challenges that you hear about nationally. I don't know that I can say those challenges have been different in Oregon because of this payment cap. Like I just don't think we have evidence that this payment cap specifically has altered things in one direction or another in that regard. I think there's been a whole confluence of factors that that factor into the hospital's revenue and how they operate, and that this policy exists alongside all of those other factors. So I don't know that we've seen a disproportionate impact in hospitals in our state because of this, the implementation of this payment cap in any way.
Oh, one more question, Woody?
Have any hospitals closed since you've enacted this legislation? Or are there any hospitals that are on the point of closure?
Yeah, so no hospitals have closed. I mean, I can tell you there have been some situations, such as things like closure of labor and delivery units, and things, but those situations have actually happened in the hospitals that are exempt, that are not under this cap. So I do think that when it comes to those types of decisions, a hospital deciding to end a type of service or close a certain unit, there's a lot of factors that go into that. And like I know I can think of a particular hospital in the state that has closed its labor and delivery unit, and that hospital is not a capped hospital. It's exempt from this cap. And I just think that, there are a variety of things that went into that decision that have nothing to do with this particular limit on the payments from the state employee plan.
And might there be other services that have been terminated at some of these hospitals based upon this?
We are not that we are aware of. We have not observed that. I mean, again, this limit is really, I mean, it's the 24 largest hospitals in the state. OEB and PEB represent 15% of the commercial market. 200% of Medicare as a cap is double what Medicare pays them. So it is still a margin above and beyond Medicare. So we have not observed or been made aware of any situations where a hospital has closed services because of this cap.
Thank you.
You're welcome. All right. So moving ahead to the next slide, a little bit now about our savings that we've seen. So as I mentioned, took effect in late 2019 for the Educators Benefit Board and January 2020 for the public employees. close to 70% of our hospital utilization occurs in capped facilities. So there is, roughly a third of our utilization that is happening either in those smaller facilities that are exempt from this cap, or happening in hospitals out of state as well. And those are not subject to this payment limit. During the first 2 years, our actuaries estimated savings at over 160 million. In 2020, the first year, we saw about 59 million in savings, which is a little more than 4% of that 1.25 billion total cost, annual cost in that year. And as you can see, as I mentioned, so on the inpatient side, we actually had a cost increase. We did not see savings, and that had to do with what I talked about a little bit before in terms of providers seeking the full ceiling rate, that full 200% of Medicare rate on every service. After we made some administrative rule changes and clarified payments occur at the lesser of billed, contracted, or the ceiling. We were able to then, in subsequent years, we've seen additional savings. And then additionally, we have higher savings on the outpatient side. So you can see in 21, that 112 million in estimated savings is closer to about 7% or so of that 1.6 billion in annual cost. And we had, again, savings there on the inpatient side, but you can see our outpatient savings are close to double what we saw on the inpatient. So a little more about the savings, and I guess I've sort of kind of touched on this already. So again, higher savings on the outpatient side, and that in large part has to do that at baseline, those outpatient services were just at a higher percentage of Medicare for the baseline. So they were running at about, on average, 285% of Medicare. Inpatient was closer to 230, 235 at baseline. And going into this, we already did have some hospitals that were below 200% of Medicare for their inpatient rates. So to some respect, this is about sort of bringing in those outliers and trying to kind of get a little bit of a more consistent payment level across providers. And it is, I think, important to note that with a cap that's set at a percent of Medicare, I mean, Medicare, when it sets its rates, does make adjustments for geographic wage adjustments and acuity adjustments and some different adjustments that are incorporated into Medicare. And those are reflected in what we pay. And that if the cap is 200% of Medicare, any adjustment that Medicare makes to rates is going to be reflected in that.
And correct me, you had mentioned that provider fees were excluded from this. So when the outpatient savings are the outpatient facility charges? Okay.
Yes, facility. Yeah, correct. Yeah, this does not include professional fees. Those are not part of the legislation. So, and to note, as I mentioned, our projected savings for the initial year were 81 million, and we fell a little short of that. We came in at 59 million, and kind of noted that I think certainly the COVID pandemic and disrupted utilization played a role in that, as well as we initially had those kind of unintended higher payments on maternity and newborn. Because they were being paid at a level higher than typical commercial prior to our rule change. In terms of impact, a little bit more detail here. So our carriers and TPAs that contract with PEB and OEB, and we have a very collaborative relationship with our TPAs and our carriers. We actively partner with them. They have maintained the networks alongside these reduced payment levels. We have not had concerns or disruption expressed by covered employees. In fact, I'm pretty confident that the majority of our employees are unaware that this policy even exists. And it sort of stands to reason when you think about it. The typical employee who maybe an expert in some other area of state government and, doesn't necessarily study the healthcare system, doesn't necessarily know how the rates that their hospitals are paid are contracted, for services. So this whole policy has been pretty, I almost want to say like invisible to our members. Like I just don't think that for the most part they have been, um, directly and invisibly impacted. Based on 2022 data, and this is a little bit dated, I apologize. We are looking at more recent numbers. I just don't have anything final as of yet. But our inpatient payments at the capped hospitals averaged roughly 165% of Medicare. And I do believe, that is because contracted commercial rates. I mean, again, that double Medicare cap is, there's room underneath that, I think, for commercial carriers to contract for less, and we have been able to recognize some of that. And then on the outpatient side, our payments are running higher relative to Medicare. That percentage, those are in the sort of 190% of Medicare range as of 22. And then additionally, analyses to date, we have not really found evidence of any disproportionate impacts to other commercial plans. In fact, I think, the fact that we are kind of running on average below the 200% of Medicare cap tells me that some of those, commercial contracts are also sort of below that 200% of Medicare level, and that we are able to recognize those rates that are available kind of in the broader commercial space. Yeah.
I'm sorry, I didn't mean to interrupt you, but did I hear you say that, I mean, not all of your plan options under both of these, OEB and PEB, not all of them are self-funded, some of them?
That's correct. Yes. The Oregon Educators Benefit Board in particular has some fully funded plans. And then PEB does have a fully insured integrated HMO as
So
well.
if you're a commercial patient just purchasing with that carrier, you can have the same plan and yet the payment amounts are different?
Well, so yeah, so this particular legislation capped the payments for the state employee population specifically. So we have heard from our carriers that, they have commercial contracts, and then they have specific contract language that relates to the PEB and OEB plans, to those particular plans that stipulates this payment cap. So this payment cap doesn't, the 85% of the commercial market in the state that is not OEB and PEB is not under this 200% limit.
Okay. So carriers will pay different rates they're not all in the same risk pool, I guess is what I'm saying. They're separate.
Well, so for the HMO plans, they do some community rating. However, we do work with them because we have this policy in place that limits. We do work with them on our rating to recognize the fact that there are some savings to the PEB and OEB plans related to this limit on hospital payments.
Okay, thank you.
You're welcome. And again, in terms of the overall goal, it really is about supporting progress toward a sustainable rate of annual cost growth. So when you think about Medicare as a benchmark, CMS does provide annual updates to rates, to their inpatient prospective payment system rates for hospitals. Those updates generally fall near or below 3.4%. And that 3.4% is the limit on PEB and OEB benefit programs. That is the sort of the threshold we have to meet in terms of if our program costs increase more than 3.4% in a given year, our boards need to look at making modifications to the benefit programs to keep our cost growth to no more than 3.4% annually. And that 3.4% number does align with Oregon's statewide target for sustainable healthcare cost growth as well. And so looking just a little bit more data in terms of what we've recognized to date in terms of PEB's year-over-year cost growth compared to large employers. And again, this is data from Mercer Health and Benefits in terms of their annual look at large employers nationally. And you can see that, that the blue line representing the annual change in total health benefit costs per employee. And for PEB, we have managed to be under that every year since this policy went into place in 2020, looking at that sort of. So we did recognize, I think, a big initial savings and then sort of a tempering, I guess, of our cost growth in that on the hospital side for these capped hospitals, our rates will, pretty much go up in line with Medicare increases annually. That's not to say that it has solved all of the cost management problems. Maintaining sustainable cost growth is an ongoing challenge for our program. It's something we are very mindful and attentive to every year. And I think that the current climate of some of the increases we're seeing now is, it continues to be a challenge. But this policy has helped us on the path to making progress on that sustainable cost growth goal. So I think I have maybe 2 more slides, just a couple more in terms of some considerations. And as I was saying, I think, payment limits are one approach to support sustainable cost growth, but continued strategies are needed. We continue to work on this. This is not the single solution in that respect. Also, I've kind of alluded to, I think, Medicare is a really useful, it's a reasonably transparent and broadly familiar price benchmark. Providers are familiar with it. Insurance companies are familiar with it. However, I do think it's helpful to thoughtfully consider nuances when you're applying Medicare levels of payment to commercial plans. As noted, Medicare may not be the most accurate benchmark for services that are infrequently used by Medicare's population. So things like maternity and neonates. And then also we have observed, I think it's important to consider how retroactive rate adjustments that CMS may provide from time to time could impact commercial plan administration. We've had a few instances where, sometimes Medicare will give a hospital a rate adjustment for a variety of different reasons, and they'll make that retroactive. And so then in a commercial plan, if you are paying rates that are, tied to a percent of Medicare, you could be required to, per the contract, go back and reprocess those claims and grant a similar increase. And so I do think, one way to consider that is if you set a limit as a percent of Medicare as of the date of service, you sort of in that way can handle any potential retroactivity. It's not something we've seen a lot, but it has happened. Additionally, I think it goes without saying that any sort of payment ceiling certainly impacts contract negotiations, but the specifics of that impact are really going to vary by community. It could influence some providers to seek increases beyond where they currently are if they're below that ceiling. It could influence providers' perspectives on value-based payment approaches and transition away from fee-for-service. I think, the specifics vary. I think in some instances, it might motivate providers to want to move away from fee-for-service and look at some alternative VBP arrangements. In other settings, it might decrease their interest in doing the work and making the investment to transition to a non-fee-for-service arrangement. So I just think that's, it's something to take into consideration. And then additionally, I think there's aspects of this policy. I love all the questions I've heard today because I think they're really good ones, and they're very much in line with this notion that I think, the payment ceiling level, exactly where that's set, what benefit programs or populations are included, which providers may or may not be exempt. All of those things are features that I think can really be informed by data analyses and local considerations. I do think that those kind of specific features are things that, can look different from state to state, just depending on the local realities. So thank you. Yeah, thank you for having me, and I'm happy to engage in any further questions if there are any.
I think we have a couple questions. Woody?
Yes, one of the criticisms on this type of program is that additional costs that the insurance company doesn't cover could fall on patients. And those costs could be unexpected. Can you explain how your state has dealt with that? Has it been a problem?
Yeah, so that has not been a problem. I think for a couple reasons in terms of the way this legislation was written in Oregon. So it's specifically the way we've implemented is the cap on services is it's 200% of no more than 200% of what Medicare would pay for network hospitals, 185% of non-network at non-network hospitals. And balance billing is prohibited. So when the legislature passed this, they specifically included in the bill language that prohibits any hospital paid under this arrangement from balance billing. Additionally, we did exempt out-of-state hospitals because largely, because that balance billing prohibition wouldn't be enforceable outside Oregon's borders. And then additionally, the way we have approached this with our carriers in terms of implementation is that if there is a service that our benefit plan covers, that the PEB and OEB benefit plans cover, that is not a Medicare covered service, so there isn't a Medicare rate for it, let's say, then it's covered just the same as it would be per their kind of commercial arrangement. So we really haven't had a situation where there have been services that weren't covered under this and somehow members ended up with more out of pocket.
Thank you.
Any other questions? I had one. All right. I was wondering, Vermont has a relatively high percentage of our population has Medicare and Medicaid, so well over 50%. And I think, one of the concerns with when we talk about reference-based pricing is, are we covering the cost of care are we subsidizing Medicare and Medicaid? I was just curious, Oregon Health Plan, I think that's the name of your Medicaid plan?
Yes. Yeah.
OHP?
Mm-hmm.
I'm wondering how their rates are comparable in the hospital, inpatient and outpatient setting in relation to Medicare rates, if you would know that. And if that was a consideration that was taken into account.
Yeah, so unfortunately, I can't tell you offhand exactly how the OHP, Oregon Health Plan rates compare to Medicare for hospital. That I do not know offhand. I mean, I think similarly, in Oregon, I mean, Oregon Health Plan and Medicare together certainly cover more than half the population or in that range, even probably a little more. And so I think, certainly when this was being looked at in the legislature back in 2017 and it was being debated, I think there was a lot of consideration about, Medicare, Medicaid, commercial, the share, what share each of those market segments had, and how that translated into, payment rates and potential cost shift. I mean, if you part of the language that exempts certain hospitals from this policy specifically notes or acknowledges that hospitals in that meet certain criteria, and one of those criteria is at more than I believe it's more than 40% of their total patient revenue comes from Medicare. So, I mean, I think there was certainly some effort at the time to really consider the various sources of revenue and how those might look different at different hospitals. So yeah, I mean, I think that's certainly a consideration, and in terms of how you think about, how this would apply, and what level of Medicare might be identified as the ceiling level, and what exemption criteria might apply. I mean, there was certainly a lot of, I think, deliberation on that in negotiations. I cannot speak specifically though to sort of the Medicaid payment levels and how those factored in.
Anyone else? Margaret, thank you so much for coming in today, joining us all the way from across the country.
Yeah. Thank you for having me.
Thank you. Really great information.
Impressive.
I think, do we have? Hi, Marilyn. Thank you for
Hello.
joining us.
Oh, thank you for inviting me.
Thrilled to have you here. So we're just, we're kind of diving into reference-based pricing and exploring, options around it and just trying to educate ourselves. And we're thrilled that you're joining us today. And you can go ahead.
Oh, thank you. May I share my screen?
Yes, please.
I just sent a request. Oh, good. You'll have to bear with me. I'm not the best at this.
That's okay. Take your time.
Great. Can you see my screen?
We can.
Great. I want to talk a bit. Thank you for inviting me, first of all. I'm really excited to see Vermont looking at this option. I wanted to talk about the Montana experience. I was administrator there from September 2014 through June of 2018. And we did implement a reference-based pricing model. So this is what we faced at the end of 2014. This is the actuary's projection of where we would be in planned reserves. We were going to be at minus 9 million in just 2 years if we didn't turn things around. So the legislature passed Senate Bill 418, which basically said that state employees would receive a 50-cent an hour raise, but future raises would be dependent on the health plan being able to turn around. So that was our challenge. What are we going to do to turn it around? So the first thing we did was take a look at our data. And we looked at our claims data for a year, and we saw that the Montana hospital facilities were 43% of our spend. We knew that's where we had to hit first. Now, of that 43%, 11% are the 13% are our 48 critical access hospitals. So only 13% of that blue piece of pie are the critical access hospitals. 87% were the 11 acute care larger hospitals. So we knew that that was where we would take our focus first. So we started studying what what could we do? And I had come to the plan, I'm an accountant, and I had been a CFO at a third-party administrator, and I had been a controller at a carrier plan. So I knew those provider network contracts and kind of what's in them. So I started digging, and this is something that was published at that time. And it was from the Healthcare Cost Institute, taking a look at utilization and intensity versus price. And this chart clearly showed what we've been reading in all the literature is that price is the issue. Price is the problem. And we verified this with our data set. We did a split variance to be able to look at utilization and intensity versus price, and we followed this same pattern. So I needed to communicate this to the legislature and the governor's office that we wanted to change our reimbursement methodology. And this is an example of a very easy cost to track, the hospital semi-private board and room. And this is, the blue line is what the charge master or billed amount is, and the green line is the allowed. So what I was displaying is that if we continue along the path of a discount off charge master, we're going to continue the trend. You're going to follow that charge master rate, which we have no control over. At that point, it was a negotiated discount with the carrier. The hospital had the ability to change that charge master rate every quarter. Most of the hospitals did, and we had no control over that price. So I found this article, and I worked with Chapin White at that time. He was one of the authors here to get a bit better understanding. And the blue dash line will show you the inflation-adjusted price per inpatient stay for Medicare versus what the price was for private. And I worked with two of the authors of this to ask them, what is going on? Why is that red price private, going up so much? And the response I got was because they can. And that kind of rang true with other things we were reading at that time. So we decided that we would change our reimbursement methodology, that we would move to a multiple of Medicare for all facility services. Now, I emphasize all because you'll have carriers tell you, well, we have some great Medicare repricing, bundles out there. But what I had seen in other plans from my experience was that you could give a bundled package at 150% of Medicare for musculoskeletal, and then the hospital would raise its prices on maternity. That was an actual example. So we wanted it for all, including what we call the J codes, which are the infusion medications or the 340B drugs. We really wanted that across the board. Now I say, excuse me, I'm dealing with a cold here. We wanted to, we hit inpatient, outpatient first, and then we did deal with professional. Those are the doctor's charges, and in most cases, we paid an increase. We were moving that target for providers up to 165% of Medicare. Now, why did we choose Medicare? It's a common reference to overcome all of this billing secrecy that's out there. It's adjusted for case mix and geography. Every hospital has a different Medicare reimbursement based on their situation, their risk scores, and their case mix. The calculation process is publicly available. And the other thing is it would move our plan to DRG and APC reimbursement methodologies, which is more of a grouper, more of a bundle. So there is a price for a knee replacement instead of all of the add-ons. We decided to contract directly with the hospitals. And we did not go through and put in legislation for the carriers or the TPAs. We put out an RFP to find a carrier that would work with us. And we had 9 respondents, and 3 said no, they wouldn't do it. One said they would stick with their bundles that are referenced to Medicare prices, but we wanted it across the board. One followed a model that they had a third-party vendor that would assess bills, and on high-cost bills, they would reprice them as a multiple of Medicare, but it wasn't under contract. There could be balance billing, and they would come in and support the member and the plan legally with lawsuits. We didn't want that. That's too much disruption in our mind for a state health plan. So we did not want any balance billing, so we needed to do contracting. Now, Montana procurement laws did not allow us to contract directly with hospitals. We had to go through a third party. So I approached the Montana Healthcare Alliance employers to see if we could hold the contracts there, and then all private and public that are members could join in, but they were not interested in doing that. So we formed a partnership with Allegiance. At that time, it was a smaller TPA, and it still is here in Missoula, Montana. And they had been studying this method, and they had a lot of good data on it. And so we did amendments to their network contracts specific for the state of Montana so that we could have the contracted rates. One thing, we needed quick results because you saw we were headed downwards, and we needed control over future increases. So most of our contracts were that the annual rate would only go up by the Medicare inflation factor or the CPI, a specific CPI, whichever was the lower. So the first thing we did was look at where our claims landed, and this is a picture of the 11 acute care hospitals that have 87% of our Montana spend. And we looked at what we were paying as a multiple of Medicare. And you can see number 7, we were paying 611%. And that particular hospital had a high utilization. We had number 9 there, 239. And some around 254. So we knew we could target around 250, but we set the target closer to 230, but we did set a range where we wanted these hospitals to come. We knew that if we could hit a target where 2 or 3 of the hospitals are, we would negotiate with them first. We looked at inpatient, and we again were trying to look around that 230, but we lowered that in our actual negotiations. And you can see that one hospital was at 191 and one was at 221. These are in a different order than the previous slide, but the 2 low ones here were low on the other slide too, and they had really good quality metrics. One was in Billings and one was in Missoula. Both towns have 2 hospitals and had quite a bit of utilization. So those were the hospitals that we approached first in our negotiations, and they came on board and actually helped us develop the methodology. And they were held out as the efficient hospitals, and we called them that in the press. We worked with them diligently to try to move the other ones in. The Hospital Association did not agree at all with our data, our methodology, and we shared it with every hospital. We gave them all of our data and all of our repricing, but the Hospital Association did not agree with it. So they let us know that the only metric they agreed with was Cleverly and Associates. Cleverly and Associates is an analytics firm that works a lot with hospitals, and they have an HCI index. It's called Hospital Charge Index, more comparing one hospital to another. So we gave them all of our data, and when we were done, we worked with Cleverly and Associates to do this graph, and their findings lined up with ours. So that was a validation point. And I want you to keep in mind that we started this probably in April of 2015, and we went live July 1st, 2016. So we were doing a lot of data analytics with the strong TPA support through this. So this became our goal. This is inpatient and outpatient. We looked at the range of where we were for blended inpatient, outpatient, and we looked at that data and we saw there was a 271 point spread in the multiple of Medicare pricing. So our goal became, let's set a range so that we can negotiate individually with the hospitals, those that are at a high point and need 2 years or so to get down. We understand that. We'll work with them. But our goal was to reach by 200 or by 2018 that there would be a spread. So we did not set the same rate for every hospital. I had a very strong Republican legislature that was opposed to price capping, price setting. I had a strong Democrat executive branch that really wanted to see the lower prices, and were very focused on the employee. So we could not do a narrow network and just name hospitals. So we were balancing all of those needs. So we created a range and did individual contracting. So this was our projection. We looked at 2016, and this was done at the end of 2016, and our plan went into place in July 1st, 2016. So that year, the 6 months, 4.6 million was achieved. And then we projected 12.7 and then 15.6. And I provided a handout to you that has a lot more detail in it in case you wanted to look at that, but we exceeded that amount. So then it came time for the end of 2017 to go back to the legislature. And instead of minus 9 million, we were 112 million to the good. We far exceeded our recommended reserves. At that time, we had more money in our reserves than the Montana General Fund at the end of the year, as it had been a very heavy fire season year. So we were lending money to the Montana General Fund. But you know, as annoying accountants, I made sure that they paid me statutory interest rate on it. So at the end of 2017, a special session was held, and we totally supported this bill, which passed, was to allow a 2-month premium holiday for the state. So the state wouldn't do their funding. We would reduce our reserves, and in essence, the state was able to keep 25 million for other purposes with taxpayer dollars, which made sense. We didn't need it anymore. This is a reserve level analysis that was done. Now, our legislature was very focused on our reserves. So that is why our slides and our discussion went that way. This was done by our actuary at the end of 2019, and you can see where we were in 14 and 15. We were well below the blue line of recommended reserves. In 2016, we were able to bring the reserves back up and then exceed it greatly. Now in 2018, we did take a bit of a dip because we did the 2-month premium holiday. We moved reserves out, but we still continued. Now through this time, there were no increases to employee premiums and no increases to the employer share. We actually enhanced benefits. We had 5 on-site health centers. We added staff, nurse practitioner level, health coaching, diabetic care club, asthma care club, and we did a few more things to enhance that primary care benefit. This, I apologize for this being vague. I took it actually from a court document, but these were the plan results through 2020. Now this brings in the professional, and the blue line, you can see where we were for our inpatient, outpatient, and professional. It really dropped down in 2016. It dropped further and it remained fairly flat. Our target for overall was 200%. with professional, but we knew inpatient and outpatient was the bulk, and that's where we needed the tough contracting. The yellow line shows some additional spending that was done, and that really was our health centers. So we did achieve the target, and we had a flat price trend. So reference-based pricing existed in Montana for the health plan from July 2016 to 2022, December. I believe, and the facts show, that it really did strengthen the foundation of the plan. Reserves were definitely built up. During that time, there were no increases to any premiums or contributions, and benefits were enhanced. And employees all had access to affordable quality care. And I really like the comment Margaret made, because we felt the same thing. If you were to ask employees in Montana what happened, they don't really know. They just kept receiving their benefits as is. They did realize, because we put this in place at point of service. So what happened was that their member out of pay or their deductible or whatever on a particular procedure is going to be lower. We wanted the member to feel it right at the point of service. Now, there are plans out there, carriers are advancing, where they will come in at the end of the year and reprice the claims to meet a particular performance guarantee or benchmark. And then if they don't meet that benchmark, they will refund some admin fees. I personally do not like that at all, because the member is the one that can potentially be hurt. You could have a claim that pays at 500% of Medicare. The member's hit with their out-of-pocket share. But then at the end of the year, if the carrier did not meet that performance guarantee, some admin fee goes back. So I think it's better to the members. My personal belief is to realize that at point of service. There was another premium holiday passed in 2021, implemented in 2022, and for 27 million. So over this span of time, there were no increases. There was 52 million returned to the state. There was we monitored hospital impact. The critical access hospitals, we pretty much kept their payment the way it was, because it was 13% of the spend. We did reduce reimbursements on 3 of the critical access hospitals that were owned by systems, as their rates were really high. Fortunately, from my perspective, on January 1st, 2023, under new leadership, the plan terminated these contracts, and they moved to a standard Blue Cross Blue Shield PPO network. And when the contract was issued, the state announced that this new program would project additional savings of 28 million. And the plan at that point had double the reserves required. So it was really good shape. But unfortunately, these projected savings have not panned out with the standard PPO network. And a bill is passing through the legislature now. It's House Bill 3, and I provided a link in the document I'm giving you. And it's moving through the 2025 Montana legislature to increase the state contribution. And that has not happened in 10 years, but they need the money now. So with these provisions, the state contributions would go up, generating 4 million additional reserves or income to the plan in 2026 and 8 million in 2027. There are some things I learned. And I think one of the things I learned is that the reference-based pricing could have been protected through legislation. And it's not unusual for a different administration to come in and want to do things differently. So it could have been protected through legislation. And quite frankly, we kind of didn't think of that at the time. Well, we did. We knew that it would take longer to do for us legislation, because we only meet every 2 years. And we would have not meet again, the legislature would not meet again until 2017, and the plan would be bankrupt by then. So we decided we had to do this outside of that. I think that it requires you to do a lot of independent analysis and monitoring, because I believe nobody watches your money like you do. So we used an independent repricer. We did not use the repricer of our of Allegiance or the carrier, because that to me was a conflict of interest. We also implemented our own data warehouse, so we would have our own data and we could oversee the pricing that was happening. And we could reconcile the cash paid because we held our own bank account. We did not let the TPA hold our funds. We held our own funds so we could reconcile what was paid on a claim compared to what the provider was paid, because there is plenty of spread pricing in medical. Couple of things we learned, and Margaret touched on these, is we came along later and we had to include amendments that said we would pay the lower of billed charges or Medicare rate, multiple of Medicare. We had situations where the billed rate was lower than the multiple of Medicare, so we needed to get that put in place. Like Margaret said, we also had the issue of some procedures done outside of what is normal Medicare pricing, like pediatrics, maternity, afterbirth care, some of that. And we got caught on that, just like Margaret did, in that it was repriced at a much higher rate for a baby on like a CPAP. It came through as a respirator. So since we had our own data warehouse and we were constantly scrubbing that and watching those claims, we were able to catch it. So I've watched some plans move to a multiple of Medicaid on some of those particular items. What we did is what Margaret did. We went to whatever the network rate was on those, and we identified those. So that is something to keep track of. The other thing we did is we were totally transparent and data-driven. It was definitely, we hired a communications firm out of Atlanta, Georgia, actually, to create videos and help us with meetings with employees, because employees were mad. They were not going to get a pay raise because of the health plan. So we needed to communicate what we were doing, and we were able to get the union leadership on board through the executive branch. We also were extremely transparent with our data, and we had situations. I remember one hospital we were negotiating with, because I had done the analysis on the Medicare cost reports, the audited financial statements, et cetera. And we were visiting with, or we were negotiating with one hospital, and they said, you can't do this because of what's happening in Medicaid. We are losing 40%. It's only covering 60% of their costs. So I went and I looked at it, and I looked at what they were recovering with those upper limit payments that are coming in. And I saw that Medicaid was covering about 85% of their costs. So yes, but then I also looked at the payer mix. So, and I didn't look at the payer mix as far as revenue. I looked at the payer mix as far as services. So they were recovering about 85% of their costs, but Medicaid services were only 9%. So that's a different story to work out. So I'm a nerdy accountant. I go to the numbers, and fortunately I had other people on the negotiation team that really kind of know better how to work through this, but that's our story from Montana.
Any Topper, you have a question? I have a couple.
Where are you today?
Me? I'm in Montana.
No. Today. In terms of, what were you doing it today?
How are they paying the plan today?
Yes.
They're on a standard PPO network discount off ChargeMaster.
So if I'm understanding, what Montana did was essentially you took the contract negotiations with the hospitals out of the hands of the TPA or the payer. And you, as the state, actually developed contracts with each hospital that was included.
Actually, what we did, because we could not contract directly per Montana laws, we had to get that as an amendment to the TPA contract. So every meeting we had, we were at the meeting negotiating with the TPA. So
Okay.
we were there together, and then the TPA wrote up the amendment, had the amendment with our approval, and we attached it to their provider network.
And so this was in effect essentially until 2022, and then to Topper's question, they're not doing reference-based pricing anymore.
No, they aren't. Mm-mm. They're
They
using a standard Blue Cross PPO network. Their first arrangement was to do a retroactive look at claims. And if they didn't meet certain targets, amount of admin fee had to be paid back. And as I mentioned, I don't like that because the member's the one that's impacted. There was a claim filed against the state of Montana for the procurement process that was used. And there were a lot of depositions and filings. And the state decided the day before the hearing to reprocure. And they did go with a straight Blue Cross Blue Shield PPO network.
Any other questions? I had a couple. I think Woody had asked had asked Margaret regarding, did any hospitals end up closing? And I'm the same to Montana. Did it affect the financial health and viability of any of your hospitals?
No, it did not. One hospital that's part of a larger system ended up signing at the very last minute because we did put in a travel benefit. We knew that we had to do this 100%. And that's when we really called in our communications specialist to work with employees. And we were actually in the city 2 days before we went live, talking to the employees and had care managers with us. And we were rerouting procedures. We were working with them because one hospital in this large system would not sign. And about 3 hours into the meeting, the hospital signed. And I don't think they thought we were going to go through with it, but we were prepared to. They ended up doing just fine. Actually, one of the senior officers was terminated over this because they had stalled so long. But no, I did include a graph in the handout of what Montana's median operating profit has been. And you can see it varies, but it's been standard right there. We did follow hospital operating costs. And through 2019, we were seeing costs come down a bit. And we did not see shifting to other payers. We checked with the biggest carriers. We checked with the Montana Alliance of Purchasers. So we didn't see the revenue price shift, and we did see some control over costs. Now it's difficult because then COVID hit. And the hospitals in Montana received so much funding, well above, we didn't have kind of the serious COVID epidemic that other states had. So the hospitals did very well during that time, but no, we didn't see that. And as I said, with the critical access hospitals, I didn't mention this, several of them received higher reimbursements. Of course, they're paid at 101% of their operational costs by Medicare. So their Medicare rate is not PPS or OPPS. So we, with the hospitals, calculated kind of an equivalent. And there were some, because of access and our member access. And of course, we were the state government. We wanted to ensure access for the citizens of Montana. We did give few an increase, but it was 13% of our spend was not major. So they did get increases. And we didn't see any hospital blowback. I think it was a time, and the governor really helped out with this, to sit down at the table with the hospitals and say, we can't do this anymore. All along, you've been able to set whatever price you want. Carriers, you've been able to negotiate. You've got clauses in your contracts for revenue neutral agreements. You've got clauses in your contracts, both of you, for all or nothing. It's time that we're getting away from that.
And I guess when we began this discussion, we were thinking about it in terms of our state employee health plan, as well as our teachers' benefit, our education health plan, which, when you calculate the number of covered lives, is I think it might be more than what is in our small group, large group, commercial, and our individual exchange, or roughly the same equivalent numbers. So, the notion that it's advantageous essentially to a state employee, even though it's the same payer, their out-of-pocket costs would be less. Obviously, if something went to their deductible, they'd have less than somebody who's on the individual exchange, same payer. And so I was wondering, how did this affect your other commercial market? And I think you sort of alluded to that when you were answering the last question. Did your commercial market continue to rise at the rate that your self-funded plan had been before you implemented this? Or did it go even more?
Yeah, I have not checked that with the commercial market as far as fully insured products. We did check with other self-funded plans through the Montana Purchaser Alliance. What were they seeing? Because there are some large employers, the utility company, Washington Court Mining, different industries in there. What were they seeing as far as their rates, their prices? And they did not see an impact on that.
So there wasn't a cost shift to...
No, they did not see any. Now, what happened then after we went live with this, Montana Association of Counties and Montana Municipal Local Authority, which are the cities, they both really wanted this same type of program. So they utilized the same amendment that we were on, and they had the same TPA, and they did negotiations just like we did. They were able to get significant reductions, not quite the level of pricing that we did. They were a little bit higher, but they did move to this method. The schools continued with a trust that they're in that didn't want to do this at all. And they're now in financial crisis, and they're trying to, they've gone to the legislature for 40 million, and they're trying to come up with a solution on it too. And it would like to look at this model.
For lack of a municipal, I think you said the municipal employees were able to start negotiating this themselves use this under their TPA. Are they still utilizing that?
Yes. Mm-hmm.
They are.
Yeah, and they used the same TPA. They used a lot of the strategies and the same data we did. So both the counties and the cities that are members of the Municipal Local Authority Trust and the Montana counties. Now, some of the large counties may not be in those. They may be self-funded on their own.
This was over the course of many years, and I think you were one of the first states to implement something like this. Are there any lessons learned throughout it that maybe should have been done differently from the beginning?
Yes, definitely. I thought, on one hand,
Could you make those mistakes so we don't do it?
no, on one hand, we had to do it fast. We only had a year to get this in place. So in hindsight, yes, the things I mentioned, I wish we would have put in the contract, the lower billed versus the rate. I wish that we had been able to, align some of those procedures like Margaret talked about that aren't covered really well with Medicare rates. I think I spent an awful lot of my time on hospital financials so that when we went to the negotiating table, I was able to better understand where they were as a system, where they were as a hospital, were the hospital rates funding these 50 new ventures that they were in. I had to know all that. And in hindsight, I spent way too much time on that. That really kind of wasn't needed. It should have been focused, but then have that as a background information. I think it really helped us that we had the two hospitals step up right away. And they wanted to be a part of this and help us. They said this is going to be fine. Now, the hospitals already bill under Medicare. They already have the systems. It's not additional expense to the hospitals. In our case, they sent the claim to our third-party repricer. The third party repriced them because we wanted the same methodology. Then it was sent to the TPA, who would look for medical necessity, but not the price side, and then mark it up by whatever that contract was. Now, that process was a little stumbly to get going at first, and there were some delays, but in time, it became like a 2-day turnaround, and payment came in faster, and the hospitals really appreciated that. And we heard a lot of feedback that they really did appreciate the faster turnaround in payment. One of the things I did that I really am glad I did was I said, I'm going to own the bank account. And I had to really jump through hoops with the state because I wanted the TPA to pull money on the account, but I wanted to be the one that reconciled it. I wanted to make sure there was no spread pricing. And again, this was the only TPA that we interviewed that would allow that. So the other thing was, how are you going to deal with out of state? We made up a term called procedure-based medical expense, PBME, but we made it sound like it was really official. And we put it in our summary plan document that if a member went to an first of all, we purchased the Cigna Wrap network. So if the person was out of state, they used Cigna. If they went to an out-of-network hospital, out of state, because all our hospitals were in network in Montana. But if they went to a not out-of-network, then we would pay the PBME, which was the relative price of Medicare to a similar facility, similar geographic mix, similar Medicare pricing. And that worked. That worked fine.
Great. Well, thank you. And if no one has told you, I absolutely adore the artwork that's behind you.
Thank you. Thank you. Whenever I get nervous, I just sit there so I can look at my puppies. So
Yeah.
thank you.
I absolutely love that. Thank you. Thank you for joining us and
thank you.
sharing your experiences.
Thank you.
Thank you. I think we're going to take a break until 3 o'clock. Our next witness is at 3.
She didn't say that.
And